Okay, ladies and gentlemen, we are starting the new course of the next topic would be trauma. Okay, जब भी आप लोग core urology पढ़ने आते हैं तो it is always fruitful कि if you would revise the topic beforehand and then because trauma right now everyone would be feeling that trauma is an easy topic and we know about trauma because most of you have done either your general surgery rotation in your HCPS or in your MS pre-training. But when we are on the floor, the story is exactly the opposite. So I think you should take advantage of these sessions and become prepared because this is one of the very common emergencies in urology. Okay, so before we start, let me give you a prologue to this session. Now, suppose if there's a young man who has been referred to you from trauma center, say about 30-ish years man, and the diagnosis is blunt abdominal trauma. He has been referred to you from the trauma center, and he comes to you in ER1. Now, just quick responses on how you will proceed in beginning to evaluate this patient. चलिए बताइए. So ER में आप बैठे हुए हैं, ये एक पर्चा ट्रॉमा सेंटर का रेफरल आया, ब्लंट ट्रॉमा abdomen, कुछ 2-3 चीजें लिखी हुई हैं. How will you begin evaluation of this patient?
Sir, first of all, we get a short history of the history and मतलब कब हुआ था, कैसे हुआ, और दूसरा सर उनसे शॉर्ट हिस्ट्री में यही पूछेंगे कि इसको कोई हेमेचूरिया नहीं हो रहा है या कोई मतलब वोमिटिंग के हिसाब से पूछें या उसके ब्लड इन स्टूल. दूसरा हम फिर फास्ट करवाते हैं उसका, तो फास्ट से हमें पता.
अभी तो हिस्ट्री में रहे, हिस्ट्री में क्या क्या पूछेंगे?
तो मतलब सर हिस्ट्री में ट्रॉमा किस चीज से मतलब हुआ था? ब्लंट ट्रॉमा है, लेकिन कौन सा ऑब्जेक्ट लगा था या किसी आरटीए हुआ है या कुछ हुआ है.
ओके.
दूसरा सर ये होगा कि टाइमिंग कितनी टाइम से हुआ है पहले.
हाँ, और यू वांट टू नो द सिवियरिटी ऑफ द ट्रॉमा फ्रॉम द हिस्ट्री. ठीक है, कितने कैसे लगा, डायरेक्शन कैसी थी. आप लोगों ने पीड्स किया हुआ है, वहां जब बच्चे में ट्रॉमा आता है तो एक पूरी कहानी लिखनी पड़ती है. ठीक है, यू हैव टू राइट स्टोरी. हाउ व्हाट वाज द लॉजिस्टिक्स ऑफ द ट्रॉमा. You have to take it out from the history to know the severity of the trauma because the severity of the trauma will reflect the clinical findings that you will receive. ठीक है. अच्छा, शक्कर में असद जूनियर. असद आप बताएं.
सर हम प्रोसीड ऐसे करेंगे, उनका जो रेफरल लेटर है, द रीजन फॉर रेफरल, वो हम देखेंगे. उसके बाद हम वी विल टेक द हिस्ट्री एज डॉक्टर रियाज हैज सेड कि मैकेनिज्म ऑफ इंजरी उसमें आ जाएगा, मोड ऑफ ट्रॉमा क्या था और सेवेरिटी ऑफ इंजरी, उससे हमें आइडिया हो जाएगा. उसके बाद हम उसके जो प्रेजेंटिंग कंप्लेंट्स हैं, लाइक इन केस ऑफ यूरोलॉजी वी विल लुक फॉर कि एनी हिमाचूरिया है या नहीं है, या कोई हिमाटोमा डेवलप हुआ है पेरिनियम में, और ब्लड फॉर्म मिएटस है या नहीं है, और पेरिएनल ट्रॉमा है कोई. तो ये चीजें
सीधा पेरिएनल ट्रॉमा. ठीक है, चलो ओके, आगे अब देखते हैं. नाउ वी हैव जस्ट रिकॉर्ड, नाउ रिमेंबर दीज रिस्पांसेस दैट यू हैव गिवन. अब देखते हैं कि ट्रॉमा के अंदर इवैल्यूएशन कैसे होती है. देन यू विल करेक्ट योरसेल्व्स कि वेदर योर आंसर्स आर राइट और रॉन्ग. चलिए आगे चलते.
Assalamu alaikum. I'm Dr. Amra. I will be presenting this topic about evaluation of trauma, and my moderator is Dr. Mazair. And our objective for this presentation is to describe the type of trauma and get to know about ATLS protocol and signs of urological injury. Definition of trauma. Trauma is originate from the Greek word meaning wound, and it implies the physical forces exerted on a person has led to the physical injury. Epidemiology of trauma. Road traffic accident are major cause of long-term morbidity and mortality in developing nation. High mortality lead to loss of income in society, and genitourinary injuries account for 10% of all abdominal trauma. Kidney trauma 84%, and bladder 8%, and urethra 8%. Early diagnosis is essential to prevent serious complication. So type of trauma in the according to their mechanism, there is blunt injury and there is penetrating injury and thermal injury. And in blunt injury, according to the impact side and site, and frontal impact in automobile collision, in steering wheel or knee imprint or dashboard, and bullseye fracture windscreen. The possible outcome of trauma may lead to cervical spine fracture, anterior flail chest, or myocardial contusion, or pneumothorax, traumatic aortic disruption, or spleen or liver injury, posterior fracture or dislocation of hip and knee joint, and head injury or facial fracture. And inside impact in automobile collision, contralateral neck sprain, head injury, cervical spine fracture, lateral flail chest or pneumothorax, traumatic aortic disruption, and diaphragmatic rupture, fracture of spleen and liver and kidney depending on the side of the impact, either right or left, fracture of pelvis or acetabulum. On the rear impact on automobile collision, there is possibility of cervical spine injury and head injury and soft tissue injury to the neck. And ejection from the vehicle preclude meaningful prediction of injury. All pattern of injury could be like a possible outcome of this kind of injury. And motor vehicle impact on pedestrian, there is possible outcome of head injury, traumatic aortic disruption, and abdominal visceral injury or fracture of lower extremities and pelvis. Or from fall from height can lead to head injury, axial spine injury, or abdominal visceral injuries, fracture of pelvis or acetabulum, bilateral lower extremities injuries, fractures. And next mechanism of injury is penetrating injury, either stab wound or gunshot wound. And stab wound, if it's happened in anterior chest, there is possibility of cardiac tamponade and within the box, hemothorax, pneumothorax, or hemopneumothorax. And left thoraco-abdominal injury may lead to left diaphragm injury, spleen, or hemopneumothorax. And if the stab wound is in abdomen, there is possibility of abdominal visceral injury and peritoneal penetration. In gunshot wound injuries, either in truncal area, high likelihood of injury and trajectory from GSW and retained projectile help to predict the injury. In extremities, neurovascular injury and fractures and compartment syndromes. The third mechanism, which is thermal injury. Thermal injury is circumferential scar on extremities or chest. And ocular trauma mechanism, burnment of escape. Electrical burn may lead to cardiac arrhythmias, myonecrosis, and compartment syndromes. Inhalation injury, either carbon monoxide poisoning or upper airway swelling or pulmonary edema.
From this, now you understand why the is important. आपसे मैंने एक सवाल पूछा था कि what will if this patient comes to the ER, what will you do? So everyone said we will take a short history. Okay, agreed. But what I wanted to emphasize is that from that short history, you want to know the mode of the trauma, because the mode of the trauma will reflect the severity of the trauma, and that severity will be a reflection on your clinical findings. So these two slides have shown you that how your history and understanding the mode of the trauma will eventually lead you into thinking what can be the outcomes or what can be the clinical pathology present in that patient, and what needs to be concentrated on for evaluation. ठीक.
So we come to the ATLS protocol, and this is like points that we have to be like followed step by step. Preparation and triage and primary survey, CU small and EBCD protocol with immediate resuscitation of the patient with life-threatening injury. And there is adjuvant to the primary survey and resuscitation. We'll come to it like one by one. And consideration of need for patient transfer and secondary survey head to evaluation of the patient history and adjunct to the secondary survey, and continued post-resuscitation and monitoring and evaluation, and at the end we'll come to the definitive care.
Now come back to the case that I've asked you in the start of the lecture. All your answers, did they have the ATLS protocol? Asad Junior from Sakar and Riaz from here. So I asked you, okay, how will you evaluate the patient? Now, if you would reflect back on your answers, uh, this is how you should proceed. Whenever a patient of trauma comes to you, whether he has been referred, the first thing that you should do is follow the acute trauma life support or the ATLS protocol, and that is A, B, C, D, E. Irrespective of what the diagnosis is from the referral area, you have to see the airway, you have to see the breathing, you have to see the circulation. Once these three things are clear, then you go to D, stepwise. You cannot, if airway is not patent, the patient is not speaking, you cannot go to B. If the patient has bilateral lung expansion, he does not require any intervention in the chest, only then you can go to C. So when a patient of trauma comes, you do not immediately jump from history into examining the urological sites for trauma. You have to see that patient as a general, because he is a patient of trauma. There can be, why you do it, because your colleagues in trauma center could have missed something that might be more acute than your emergency. Okay. Now let's go stepwise and how to proceed.
So preparation is to include team assembly. All hospital managing severe trauma should have a dedicated trauma team who are available immediately to attend and manage the patient. The team include doctor from emergency department, anesthetist, and general surgeon, and orthopedics, radiologist, and hematologist. The role of trauma team is to apply principles of advanced life support, ATLS, to rapidly identify the life-threatening injuries. And come to the next, step is disaster triage category, which is color coded and according to priority for intervention or for treatment. So red, yellow, and green and black. And red come to as the first priority, which need emergent and immediate treatment. For those guys, they have threat to life or limb or an organ. And in yellow, second category, which need urgent and a bit delayed need for treatment for those patients who have significant injury or illness, but can tolerate and a bit delay in care. And there is a green, which is third in priority, with minimal or minor need for treatment and can safely wait for treatment. And in black, which is zero priority, either they are dead or expectant. Their need for treatment either none or just comfort care. They don't move or expectant consider transport and care after initial rates has been cleared, and if resources exist and does not delay the care of the ELOs. So the primary survey, the aim of primary survey is to identify and manage the most immediate and life-threatening pathologies. Follows the C small and ABCD protocol. C small is stand for catastrophic hemorrhagic control, and A, airway maintenance with the restriction of cervical spine motion, and B, breathing and ventilation, C, circulation with hemorrhage control, and D, disability assessment of neurological status, and exposure environmental control.
Okay, now this is important, so I'll just take a little stress here. How will you assess the airway? Anyone who has been doing it, how will you assess if the airway is patent of this patient? Batayeng, Dr. Yumna, yes.
Or anything, see if it's making sound or replying or not.
Okay. So if a patient is speaking comfortably, most probably the airway is patent. If his airway is not patent, then what do you do if the airway is not patent?
Then there are certain maneuvers इनमें जो है क्या कहते हैं, एक jaw thrust आप करके देखें, उसके बाद आप मुंह में देखें the tongue is rolled back or not, tongue को आप ठीक करें और उसके अंदर आप एक airway डाल दें.
So a patient
with inline cervical spine movement.
Bilkul. Cervical spine has to be immobilized until proven otherwise. This is the principle of ATLS. Okay. Next, how will you assess breathing? If the airway is okay, and then you can move on to B, that is breathing. How do you assess breathing?
Check breathing with a stent on a bilateral side. If the sounds are fine, then it's okay. If there is absent sounds on one side, then you percuss, and if there is hyper resonant sound, it means there is no pneumothorax, or the sound is dull, it means there is hydro or blood present, so you put in a chest tube right then and there.
Okay.
Don't wait for the imaging.
Okay, so once that is done, anyone else, how will you assess circulation and hemorrhage control? Anyone else? Jaldi se bata dein, this is basic surgery. Anyone else? कौन है? मरियम बता दें, बख्तावर बता दें.
There's a continuous hemorrhage going on from one side, then you can apply the pack or some pressure control over there to control the hemorrhage.
And if you cannot
And-
see the hemorrhage,
Then
how will you know that the patient is bleeding?
with the
Pulse.
chest movements, vitals and the pulse. Yes.
Vitals and pulse.
Pulse vitally examination.
ठीक है. So until you control that hemorrhage, you cannot move on to D. What is D? Disability. What do you mean by disability? Anyone? Basic FCPS general surgery जिन्हें IM दे दिया, they have cleared the station. Nadia बताओ.
We will see for any gross deformity like a fracture or any laceration at any site.
Evaluate the GCS of the patient. If he is alert,
वो तो हमने कर दिया
speaking
ना A में.
verbally.
A में हमने कर दिया. Now we have already cleared A, B, and C. It usually D does not come on the same day. Sometimes the evaluation of the disability takes a long time because you need to control the hemorrhage. You have to stabilize the patient. Once you stabilize the patient, control the hemorrhage, source of hemorrhage, only then you can go for the evaluation of the disabilities. Sometimes in our settings, we can evaluate on the same day because we have a urological service, but those in trauma, the secondary disabilities are usually dealt after the hemorrhage is controlled. Okay? So, E, what is E? Exposure control environmental. ये कहाँ कराते हैं?
Sir, you have to expose the patient from head to toe, and you have to check from head to toe, both on front side and back side.
Okay.
This is called exposure. Any head injury or something.
For example, if a person has been thrown out, if a person has an acid, his clothes have the substance of the corrosive substance. वो निकालने में होता है. You remove him from the harmful area that is causing to prevent further damage. ठीक है. Then next, let's quickly move on.
10-second assessment role, which is very vital in trauma setting. It's like, 10-second can tell you a lot about the status of the patient and how can you go ahead with your evaluation. So asking the patient simple question like, what's your name, and asking what happened. If there is any appropriate response, that will tell you there is no major airway compromise, as there is ability to speak clearly. Breathing is not severely compromised, as there is ability to generate air movement to permit speech, and level of consciousness is not markedly decreased, as he is alert enough to describe what happened. So we'll come to the ABCD protocol, which C small stand for catastrophic hemorrhage control. This one with apparent bleeding, you have to be controlled immediately before other ABCD categories. So control the bleeding either by application of pack and pressure or by application of tourniquet or hemostatic dressing. Second one is airway maintenance and with the restriction of cervical spine motion. A patient with decreased level of consciousness or inadequacy for inadequacy for protective reflexes are prone for airway obstruction and aspiration. For sign of airway obstruction, inspection of the inspection for foreign body, identify facial, mandibular, and tracheal and laryngeal fractures or other injuries that can result in airway obstruction and suctioning, severe head injuries. If the patient is able to communicate verbally, the airway is not likely to be in immediate jeopardy. All patients should be considered to have cervical spine injury until proven otherwise. and this has significant implication of the airway management. The head and neck should be supported at all time, especially during rolling. It may require the removal of blood and vomitus and foreign body from by either posture or by sectioning. There is maneuvers that can be done to keep the airway patent, either jaw thrust or chin lift maneuver, and through insertion of oropharyngeal or nasopharyngeal airways, or endotracheal intubation, or establishment of surgical airway like tracheostomy. In the presence of head and facial injuries, the tube should be placed via mouth.
Okay. Two things. Spine and cervical spine stabilization, and the passage of the ETT via the mouth or any tube via the mouth in terms of head injury. What is log roll? FCPS का question है. What is log roll? Hassan, तुमने FCPS किया है, बताओ. What is log roll? These are important things that you need to see in the patients of trauma. Specifically, it's important thing. Jaldi se batao, what is log roll?
Sir, in log roll, there has to be a movement in which your spine is stabilized and you turn the patient one way, just like a log of a wood is rolled. Basically, it is example from there. And you, there are 3 to 4 persons who have a specific type of movement, which is one person is holding from the head, the 2 persons from spine, and then just turn the patient toward one side.
Good. That's nice. So in head injuries, if there's suspected head injuries, why do you place the tube via the mouth? क्या चीज बचाना चाह रहे हैं? बताएं. And
So cervical spine.
नहीं, you're passing a tube via the oral tract, not, for example, एक NG डालना चाह रहे हैं, but you don't put it through the nose, you put it through the mouth. Why? Base of the skull. ठीक है, आगे चलें.
So deep breathing and ventilation. We should inspect for cyanosis, tachypnea, and look for the neck and chest. There is any jugular venous distension, say that when cardiac tamponade or tension pneumothorax, the position of the trachea, if there is any deviation, if there is any subcutaneous emphysema or chest wall excretion like inflamed chest, and visual inspection and palpation and percussion and auscultation. Significant injuries to the chest, tension pneumothorax, massive hemothorax, open pneumothorax, and tracheal or bronchial injuries. Use of pulse oximeter for oxygen saturation and arterial blood gases if feasible. In tension pneumothorax, the sign will be hyperresonant note on the percussion and deviated trachea and distended neck veins and absent of breath sound in the affected side. And in massive hemothorax, there will be loss of more than 1500 ml of blood or continuous blood loss more than 200 ml per hour for 3 to 4 hours, and persistent need for blood transfusion. And C, which stands for circulation and with hemorrhage control. The maintenance of adequate tissue perfusion, especially in the brain, is primary objective for the circulatory phase of the primary survey. So hypovolemic is is almost always due to blood loss in trauma patient. Bleeding, external hemorrhage, either like you can control it either by direct manual pressure on the wound, tourniquets it may lead to massive exsanguination and risk of ischemic injury when direct pressure is not effective and the patient's life is in threat. So blind clamping, which may lead to damage to the nerve and veins. Bleeding, internal hemorrhage, chest or abdomen or retroperitoneal pelvis and long bone. It need immediate management identified by physical examination and imaging. So the most bone-like sign is shock. So shock is likened on 4 classes. And according to the blood loss in class 1, there will be less than 750 ml of blood loss, and in class 2, 750 to 1.5 liter, and 1.5 liter to 2 liter in class 3, and more than 2 liter in class 4. And the signs will be like a heart rate less than 100 in class 1, class 2 more than 100, and class 3 more than 120, and in class 4 more than 140. Blood pressure will be normal in class 1, class 2 will be also normal, and will start decreasing in class 3 when there is almost like 30 to 40% of blood loss. And in class 4 will be decreased when there is more than 40% of blood loss. So, and one of the most vital sign that you have to be like, aggressive and looking for it is urine output. More than 30 ml per hour in class 1 will be urine output, and in class 2, 20 to 30 ml per hour, and in class 3, 5 to 15 ml per hour. And class 4 will be like negligible or none in class 4 shock. And in CNS, like, the patient will be either slight anxious or normal, mildly anxious in class 2. And in class 3, he is anxious and confused. And in class 4, he will be confused and lethargic. And for fluid replacement and resuscitation, in class 1, he may need crystallite IV and crystallite in class 2. And in class 3, he may need crystallite and blood, and in class 4 also.
Okay, so now we all know this table. How will you apply it? ये तो एक theoretical हो गया ना, but how will you apply it? Anyone? What is the way to apply it? Dr. Ahmed Rashid, how will you apply this table? If I ask you what is the classification of this patient's shock, so how will you apply this classification?
Sir, first we have to check for the ATLS,
Okay, then
and according to the ATLS, then you can see which category that it will fall.
so the most important thing that you need to see is these 5 things. One is the pulse, blood pressure, heart rate, CNS, and the urine output. When you have these 5 information, you have an assessment of the degree of blood loss that this patient can have. So the patient will not come to you saying, I have had 1500 ml blood loss. Looking at the clothes or looking at the extent of internal damage, looking at the 5 vitals, you can have an assessment on the degree of blood loss. You can classify that shock, and you can manage the resuscitation of this patient. Okay, next.
And managing circulation, patient will need vascular access to light bore, peripheral venous catheter, PT gauge, and blood sample for baseline and hematological studies are obtained, including pregnancy tests for all female at childbearing age, and blood type and cross matching, and assess the shock, blood gases, and lactate. Peripheral site cannot be accessed, so we have option either intraosseous infusion, central venous line, or venous cut down, and initiate IV fluid therapy. IV fluid therapy should be warm, crystalloid, and bolus of 1 liter, and isotonic solution. And if the patient is unresponsive to initial crystalloid therapy, should be reassessed for blood transfusion. Massive transfusion protocol, you can provide blood and along with other blood products, and the ratio of 1 back cell, 1 FFPs, and 1 platelets. And tranexamic acid, 1 gram IV over 10 minutes, followed by further 1 gram dose over 8 hours. Administered within 3 hours of injury, should be given to all patients with systolic pressure less than 110 and or pulse more than 110 per minute. Disability assessment, disability with assessment of neurological status. Glasgow Coma score should also assess should be assessed for level of consciousness and determine the level of consciousness using EVBU mnemonics. A, the patient is alert, V, verbal stimuli, and B, painful, responsive to painful stimuli, and U is unresponsive. And check for the pupillary size and reactivity. In conscious patient, all limbs should be assessed for movement and sensation to detect possible spinal injury. All patients with Glasgow Coma scale score less than 12 should be should have aggressive airway management, including early intubation. This will enable control and ventilation, control ventilation, and the ability to focus on circulatory status. Glasgow Coma scale, and there is 3 things that you have to assess: is the eye opening, is it spontaneous and responsive to sound, or responsive to pain, or there is no response. And in verbal response, is the patient disoriented or confused, or he just responding with words, or just only undistinguishable sounds, or he is not responsive. And motor response is either the patient is obeying commands or localizing the pain, or there is normal flexion or abnormal flexion or extension, or there is no response. And there will be the scale scores in mild injuries, 13 to 15, or moderate 9 to 12, or severe 3 to 8. And exposure and environmental control. The patient must be adequately exposed to allow through a systemic clinical examination, must be kept warm during this process, warm blanket and external warming devices. And when you are giving intravenous fluid, should be warm and warm environment. Log rolling should not occur until pelvic fracture has been radiologically excluded. So after we finish our primary survey, there is adjuvant to the primary survey and resuscitation. That will may help. Continuous ECG and pulse oximeter, CO2 monitoring and assessment of ventilatory rate, and ABG measurement. Urinary catheters to monitor urine output and assess for hematuria. Urine output is contraindicated, and urine catheter is contraindicated if there is any blood at the external meatus. Blood in scrotum or DRA prostate cannot be palpable or high riding. Gastric catheters, NG tubes, assess for evidence of blood and check the blood lactate, and X-ray examination for chest and pelvis. And there is role of extended focused assessment with sonography of trauma, EVAST, and DBL, diagnostic peritoneal lavage. Is rapidly performed invasive procedure that is sensitive for the detection of intraperitoneal hemorrhage. So the EVAST component, subxiphoid precardium, you will look for the any cardiac tamponade, and right upper quadrant, Morrison pouch, and right Morrison pouch, you will see if there is any collection Morrison pouch, which may indicate liver or renal injury. On right side, right costophrenic angle for hemothorax, or lower and left upper quadrant, splenorenal races, if there is any splenic injury, and left costophrenic angle. And in pelvis, you will see the bladder or pelvic collection, or in lung, you will check for apical and mild mid clavicle, or where suspected pneumothorax. This is for DBL, diagnostic peritoneal lavage. And at the end of the primary survey, consideration for the need for patient transfer. It's important not to delay transfer to perform and in-depth diagnostic evaluation. Only undertake the testing that enhance the ability to resuscitate and stabilize the patient to be safe to be transferred. If there is no trauma team, or the patient is not in tertiary care hospital.
Now, the word attempt means that it is of support to your clinical examination. What the slide says is that if your eyes and your clinical examination, your hand tell you that this patient is in danger and requires surgery, do not wait for your ultrasounds and for your lactate levels, ATP levels. If the patient is bleeding from inside and he requires immediate shifting to the operation theatre, he will be shifted to the operation theatre. These adjuncts come into mode when you think that there is equivocal finding and you need to be monitored. That the peritoneal lavage technique is for now just mentioning purposes that with the presence of more extensive imaging techniques, detail is now not performed. But it is there just for a mention because it is there at the moment.
So secondary survey head to toe evaluation. Secondary survey does not begin until the primary survey is completed. The secondary survey is detailed systemic head to toe examination in order to detect all injuries and enable planning for definitive care. During the secondary survey, all components of primary survey should be repeated and the team should be responsive to any new finding that might miss in the primary survey. Secondary survey, patient history. There is mnemonic umbilical history for trauma survey. A for allergies, which can be collected either from the patient himself or his family members or from those patients and those guys who attended the patient during the injury, if it's feasible, or is he on any medication? We care too much about if he's on any blood thinners or any further intervention, and if there is any past medical history, and last meal, or in case if there is any intervention to know when he was MBO, and events surrounding the injury. It will tell you a lot about in the mechanism of injury and what expected outcome of that injury we can expect. History may need to be gathered from family members or ambulance services. So adjuncts to the secondary survey, additional X-rays, examination of the spine and extremities, CT scan of the head, chest, abdomen, and spine, and contrast, urography, angiography, or transesophageal ultrasound, or bronchoscopy, or esophagoscopy. These things will be done according to what you have found in the primary survey or in the secondary survey history and examination. So directly which investigation you should go for. And continued post-resuscitation monitoring and reevaluation. Continuous monitoring, vital sign, oxygen saturation, and urine output, and relief of the severe pain, and tetanus vaccine and antibiotics. And at the last will come the definitive care. Definitive care in all trauma patients need to be directed by the trauma surgeon or the team leader. Definitive care involves specific investigation like CT scan, head, chest, consultation with other specialty term, neurosurgery, orthopedic surgery, and vascular surgery, and documentation of all injury and treatment. Specific management plan from all appropriate teams, and definitive placement to appropriate specialty team. So another section is briefly will describe some signs of the urological trauma, which will be conducted in the next three presentation yet to come. So large retroperitoneal hematoma, it will present as shock, or palpable mass may represent a large retroperitoneal hematoma, or perhaps urinary due to urinary extravasation. If the retroperitoneum has been turned and free blood may be noted in the peritoneal cavity, but not palpable mass will be evident. So a kidney injury, there may be a microscopic or gross hematuria, tenderness or ecchymosis over the flank region or upper quadrant of the abdomen, and lower rib fracture, diffuse abdominal tenderness on palpation, or acute abdomen indicate free blood in the peritoneal cavity. Abdomen may be distended and bowel sound may be absent. So this is sign of Gray Turner sign, which indicate retroperitoneal hematoma. And in urethral injury, there may be microscopic hematuria, sign of acute peritonitis may be present if urine extravasation into the perineal cavity, watery discharge or blood stained discharge from the wound, and bladder. There will be heavy bleeding associated with pelvic fracture may result in hemorrhagic shock, usually from venous disruption of the pelvic vessels, or an acute abdomen indicate intraperitoneal bladder rupture. A palpable mass in the lower abdomen usually represent large pelvic hematoma. On rectal examination, landmark may be indistinct because of the large pelvic hematoma. And at the end, urethral injury, blood at the urethral meatus is single most important sign of urethral injury. Suprapubic tenderness and in the presence of pelvic fracture noted on physical examination. A large developing pelvic hematoma may be palpable, or perineal or suprapubic contusion are often noted. Rectal examination may reveal a large pelvic hematoma with prostate displaced superiorly. Thank you.